Surescripts has a legacy of convening the industry like no other. And we continue to do that today as we look to continue to improve patient safety, improve e-prescribing, and that's what we're going to be talking about today. But it's not just connecting the pipes, it's actually what's in them. Actionable patient intelligence in what we share is what makes the difference.
With Surescripts' help and the ability to transit prescriptions, we have a pretty good knowledge of a medication that's been prescribed. But once that's done, everything else around it becomes a lot grayer.
We should be able to capture the change from one medication to another, and we should be able to effectively click a button in our workflow in the EMR that triggers as part of a discharge summary or as part of your encounter document, your CCDA that you're handing to a patient or they're surfacing in their portal. You are being changed from this medication to that medication. These are the consequences if you continue to take both together. You know, these are the opportunities for an adverse event, or these are the things that are going to happen. But yet it's not, like, we haven't worked that process into our thinking yet. We haven't prioritized that level of patient safety protocol.
Patients have a lot more medical problems. They're staying alive longer today. They're on multiple medications. They can't keep track even with friends and family helping them. So I think there's a huge disconnect there that we need to address.
One of the great things Surescripts does is they bring us all together at a table, and I've learned a lot listening to what the pharmacists want and need from what a provider wants and needs and what a PBM looks at it. And each person looks at the same data very differently, and so it's not just the data themselves, but even their perspectives and what those different people need. And so that's been helpful, I think, as an industry we kind of work together across the systems and understand here's why the pharmacist considers this important, where the provider doesn't really care what the packaging of the drug is, but the pharmacist really cares about the packaging of the drug, and just those things make an opportunity for errors or mistakes or miscommunication.
Where we see the standards for the script standard will really prevail is in the area of the Change RX, where now we would have a way to communicate what that pharmacist is finding as potential problems, whether that's whether we're hearing from a prior authorization situation or this drug just isn't right for this particular patient, that will now have the ability to come back and ask for a change in prescription. But more than that, even the cancel RX, where you will now be able to know that the physician wants to cancel a specific prescription, because that isn't often communicated, and this leads to poor med adherence and miscommunication on the patient's part about the medications that they're taking.
When you send a transition to care document, the thing that every doctor wants is that dictated summary or that handwritten summary that someone who took care of the patient full time knows what's going on and condenses into a simple transition document. Instead, you get a long list of data, unassociated, out of context, and you can't make head nor tails of it.
With products like Surescripts, we're able to actually make the exchange of that type of information, because the pharmacies know if a medication is not actually needs a prior authorization, or that medication can't be filled. And so having that bidirectional exchange of this type of information with Cancel RX, RX Fill, the electronic prior authorization, med history, are all ways to exchange this information so that we can be sharing that.
Right now in healthcare, everyone kind of gets their own copy of the data, and everyone looks at it differently. One thing Surescripts is leading and others are leading now, where you won't everyone have their own copy, but you kind of have that source of truth for that information, and then it gets passed around from whoever needs to see it. I think that will make a big difference.
Having something like Cancel is a first step. I still think there are issues because I can cancel my prescriptions, but as a specialist, I was most often canceling someone else's prescription and replacing it. It's great to improve the doctor's workflow. It's great to make the pharmacist more efficient, but at the end of the day, we're still stuck in this old paradigm of doctor and patient as a single entity. But now it's an entire care team. There's a pharmacist involved, there's physicians involved, nurses, mid-levels. It's an entire care team, especially as you start working with chronic illnesses, which I think is the biggest thing that we need to crack. Getting an entire care team that can collaborate, I think, would be a huge step forward.
If we're going to combat opioid abuse, we have to be able to have means for practitioners in all settings to look at the prescription drug monitoring.
From a strategic perspective, I think that with the reach that you have and the market value and the data that you have, I think that you have the opportunity to analyze what quality measures would work.
From the pharmacist perspective, Surescripts has really helped with the promotion of e-prescribing, realizing that most of the financial burden falls on the pharmacies for the prescribing, but they see the value from a quality standpoint of having a clean prescription.
One thing that Surescripts really helps is because they do see and work with many different EHR vendors, they give some great best practices as we start to implement. In the end, we all want to do what's right. We're all trying. It's just sometimes more difficult than you think it is. And so when we do get feedback, that really makes a big difference.